When you have a spinal cord injury, because the dorsal column, right, so you have the dorsal column medial lemniscus system, and you also have the anterolateral system, right? Anterolateral system is going to be primarily involved in pain and temperature, whereas the dorsal column medial lemniscus system is basically going to be involving things like fine touch, as well as proprioception, as well as vibratory sensation. Now, each of these pathways decussate at different regions in the central nervous system. The dorsal column medial lemniscus system is going to decussate at the level of the medulla. Okay, so it's going to go all the way up to the brainstem, and that's when it decussates across, right? In other words, it remains ipsilateral in the spinal cord until it gets to the medulla, and then it crosses over. Okay? Versus the anterolateral system, which is going to be involved in pain and temperature, that system decussates at the spinal cord. So those sensory afferents come in and they cross right over at the spinal cord, and then they go up all the way to the thalamus until they go up to the somatosensory cortex. So in other words, if you were to sever one side of the spinal column, left or right? In this case, this is going to be the person's left side. So you sever the spinal cord. You have a lesion right there. You're going to get an area where you have total loss of sensation. But then you're also going to have an area where you're going to have reduced pain and temperature, and an area where you have reduced proprioception and vibration. Okay? The pain and temperature area is going to involve your anterolateral system. Okay? Anterolateral system, which decussates at the spinal cord itself. And then the vibratory and proprioception type of sensory input coming from the dorsal column medial lemniscus, it is ipsilateral, same side, until it gets all the way to the brainstem and then crosses over. So you're going to see each side of the body having different types of loss, right, in terms of like sensory input. So if you had a lesion on the left side of the spinal column, the right side is going to lose pain and temperature, right? Because that's going to be associated with the anterolateral system that decussates at the spinal cord. Versus discrimination, vibration, medial lemniscus, right? Dorsal columns goes all the way up to the spinal cord until it gets to the medulla and then decussates. So that's going to be something that you're definitely going to see on your exam. I'm going to have questions like this on the test. So you'll see what kind of sensory input you're going to lose when you have a spinal cord lesion. Okay, are we good on that?
Yeah, so if the left side is severed,
yes,
the right side loses sensation of temperature and pain,
yes,
and the left side is just...
So the ipsilateral side of the lesion, you're just going to lose proprioception and vibratory sensation, fine touch, right? So in other words, contralateral pain and temperature loss, ipsilateral vibratory proprioception and fine touch. So if you're comfortable with that, you'll be good. So referred pain is a really interesting phenomenon, and this is something that's used in clinical medicine all the time. Like whenever you ask a patient, describe your pain, they'll say, I have this pain that's kind of right here. You say, point with one finger where the pain is. You're like, okay, right here. And you're right there, you're probably thinking, this might be gallbladder. Okay? So if it's gallbladder, you can say, now, does the pain radiate anywhere else? And when we say radiate, does it go like spread anywhere else, or is it just isolated in that one region? If it radiates elsewhere, that can actually help you like hone in on your diagnosis. So for gallbladder, for example, it's not really depicted on this image over here, but gallbladder pain would radiate to the back. You would feel pain around the right upper quadrant, and then you would get the pain radiating to the back, maybe up to the shoulder as well. If a person comes in with chest pain, they're like, oh my God, my chest is hurting, I have shortness of breath, I'm sweating, right? They're probably having a heart attack. That's like one of the first things you want to think. It's like, this might be a heart attack. Does your pain radiate anywhere else in your body? Yes, it radiates. I'm feeling pain on my shoulder, my arm. I'm feeling pain in my neck. I'm feeling pain up in my jaw. It's also kind of hurting in my back as well. That's called radiation of pain, right? And that's going to be associated with referred pain. Now, the reason why you get referred pain, this is going to be something that's associated with visceral pain, is that a lot of these tracts and columns, they kind of move close to each other, right? And so, especially when they get to your spinal cord, they're all going to be kind of really close by each other. And so, if one axon is receiving lots of pain stimulus and it's like firing like crazy, then it's probably going to start stimulating some of the adjacent axons as well. Okay, so it does cause depolarization of the nearby axons. So that's one of the mechanisms behind referred pain, which is going to be associated with visceral pain. And so these are all going to be transmitted through the dorsal column, right? Dorsal horn. And again, it's because they're going to be running in similar tracts in parallel. So we did the heart, referred pain, left arm, hand, as well as up to the neck, a little bit to the back as well. If you had gallbladder pain, again, it might go back to the scapula, the back, the shoulder, right? It's not depicted in this image, though. It's kind of annoying. Urinary bladder, you might get pain like in the around the inguinal area that might radiate down to the thighs as well, maybe towards the back. So these are all different types of referred pain. So another thing that you might see too with visceral pain, right? Visceral pain, like it runs through the dorsal column, medial meniscus. Visceral pain could potentially be treated by certain procedures that basically wipe out regions of the spinal cord. So these are called myelotomies. And so they'll go in and they'll actually wipe out a region of the spinal cord so that they can address a patient's severe pain. So like pelvic, abdominal viscera, you're going to see those regions synapse to the lumbosacral spinal cord. So pelvic, abdomen, it goes to the lumbosacral spinal cord. A lot of that has to do with the cauda equina, right? So cauda equina is where you see the spinal cord end, right? Then it becomes those fibers that basically go down to the sacrum and they innervate the pelvic region. Those are going to be in the lower region of the spinal cord. You also have a lot of your viscera basically synapsing with the thoracic region of the spinal cord. And so how could this be used in a clinical setting? So there was a case of a patient with colon cancer. Colon cancer in the colon can be extremely painful. And in this case, the person didn't respond to any analgesics. Nothing was able to help address the pain. So they had to go in and literally do a myelotomy. So they put in a little needle and then they just wiped out the tracts associated with that region. Right? So they went in at T10 to be able to wipe out that tract. And only then were they able to address the pain for that patient. And this is terminal colon cancer. The patient eventually died. But at least for the last 3 months of their life, they were, their pain was alleviated. Yeah, they would lose sensation to every single organ that's below the area that was wiped out. Yeah. Here's another study. This is probably one of the rudest studies I've ever seen done on animals. But this was an fMRI study done looking at the thalamus of monkeys. The monkeys were subjected to noxious distension of the colon and rectum so they could induce visceral pain. And I was just thinking to myself, there's a thing called IACUC when you're doing animal research. You have to run through a committee. You have to do your proposal for a study and be all right, this is the kind of study I want to do. We're going to be, subjecting rats to a certain chemical that might wipe out a portion of their brain. And then we're going to euthanize the rats and we're going to do it in a really ethical way. So it's pain-free. And then we're going to, do a microtome and cut the brain in pieces and then do immunohistochemistry and look at it underneath the microscope, etc. How the hell did they say, we're going to distend the colon and rectums of these poor monkeys and we're going to see what kind of effect it has in their brains. I'm surprised I even got through an IACUC. I don't know, actually. I'm not sure what year that was published, but regardless, totally insane.
I feel if it was older, they wouldn't even. Because now, I bet they could.
Yeah, it might be tougher now. I know like ethics have definitely evolved over time, but still, it's crazy. I was talking to my colleague about this one. I'm like, why do they do that? But I guess it's the closest point of entry to the viscera, right? That's the closest point of entry, and so that's why they were doing that. Anyways, so here's the lesions. Sorry, this is when they actually did the lesion on the dorsal column at T10, if I remember correctly. And then over here is a sham lesion, so that's the control. They did a fake type of lesion on the monkey. And so this is before surgery. If they did that procedure where they're doing noxious distension of the colon and rectum, you see those areas of the brain lighting up. It's like, ooh, that hurts. Okay? After they wipe out the regions in the dorsal column at T10, you see the sham lesion, the monkey's still experiencing that same exact type of pain. But 4 months after surgery, with the one that actually got the dorsal column wiped out, nothing. There's no perception of pain whatsoever. So pretty interesting stuff. Still, I think, extremely rude study. 1996, that's when it came out. So it's right there. I don't think that would be approved nowadays. I don't think. It's horrible. I don't know. I just found that really weird, like amusing in certain ways. Anyways, anterolateral system. Remember, you do have a lot of parallel pathways, right? They're all kind of like moving in concert together. You have your lateral spinal thalamic tract, anterior spinal thalamic tract, all that. They all basically move in parallel. The anterolateral system allows for sensory discrimination. So location, intensity, quality of noxious stimulus. It also synapses with the ventral posterior lateral nucleus of the thalamus. So we're going to talk about the ventral posterior lateral nucleus again a couple times here, as well as the ventral posterior medial nucleus. And then you have affective motivational system coming into play here. So this is like the psychological sensation involved in pain. And so we're going to talk about some of these regions in the brain. Some of them involve like the limbic system, the amygdala, the cingulate gyrus, insula. These are going to be like the emotional reactions that you have to painful stimulus. So unpleasant feelings, fear, anxiety, and so forth. Here is the anterolateral system. So this is brainstem to the forebrain. And so if you see on the left side over here, this is going to be your first pain sensation. So that's going to be transmitted, for example, by your A delta fibers. That's going to be your very first pain that you feel. And then it's going to go up to the ventral posterior lateral nucleus of the thalamus, and then it's eventually going to wind up in the somatosensory cortex, both primary and secondary somatosensory cortex. Then you have the affective side. So that's going to be on this side of the chart over here on the right. So affective, meaning like the emotional reaction to stimulus. And so the regions of the brain that are involved in that involve the amygdala, right? Threat perception. Is this painful stimulus a threat to my life? The hypothalamus, which is also going to be involved in like emotional processing of pain. The superior colliculus, that's going to be vision, right? When the superior colliculus, which sits in the back of the brainstem, gets activated, that kind of gives you a more like heightened awareness of like your visual surroundings. You also have the periaqueductal gray. This is where you get all three of your endogenous opioid type compounds being secreted and released. So endorphins and enkephalins, we're going to talk about that in a little bit. The periaqueductal gray sits in the brainstem. And then the reticular formation. What does the reticular formation do? We already learned about this before. Do you guys remember? Makes you what? Yeah, it wakes you up. Yeah. So like anesthesia. When you anesthetize a patient and you knock them out, render them unconscious, you're basically inhibiting the reticular formation from activating it all. When you're alert and you're awake, when the reticular formation gets activated, that alerts you to something that you should pay attention to. And so that's what's going on with the affective sensory perception of painful stimulus. So this is all considered the pain matrix. So ventral posterior medial thalamus, somatosensory cortex, the insular cortex, as well as the anterior cingulate cortex. Insular cortex, we talked about that before as well. That's going to be associated with like empathy, emotion, social relations. It also is involved in other functions as well. But when it comes to like, emotional processing, insular cortex is definitely going to be important in that. Anterior cingulate cortex is also going to be very similar in terms of how it communicates empathy to. Sorry, hold on a second. Where it's going to be involved in like empathy and like higher executive function. Facial pain, again, remember your trigeminal ganglia is going to be involved in that. So you have a trigeminal thalamic tract. It's going to wind up to the thalamus, those pain sensory inputs. And eventually the thalamus, you're going to see ventral posterior medial thalamus being activated in that process. So here's a breakdown of all those different pathways. So from the body, right, you get pain signals coming in, right? This is like anterolateral system. It's going to decussate at the spinal cord and move all the way up to the spinal cord through the brainstem until it makes its way to the thalamus. So these are your second order neurons. First order neurons outside, peripheral. Second order neurons up the spinal cord to the thalamus until they synapse with the third order neurons where they go from the thalamus to those somatosensory regions in the parietal lobe. And then here's your facial inputs, right? They're going to come in through the trigeminal ganglia. They're going to make their way up to the thalamus. And then from the thalamus, they're going to go up to the corresponding regions in the somatosensory cortex. So anterior lateral system, touch, pain, temperature, right? When it comes to temperature, these are going to be the receptors involved. We already talked about some of these already, right? We already discussed the TRPV1 receptor, which is associated with hot, capsaicin from peppers, right? TRPV4 is also going to be associated with pain from temperature. Cool, when it's too cold, these are the other receptors. TRPA receptor, TRPM receptor. Okay, V stands for vilanoid. I don't know what A and M stand for, so I apologize. But TRPV1, TRPV4, heat. TRPA and TRPM, cold. When you are itchy, they call this pruritus. That's the medical term for itchiness. If you have a pruritic lesion, that means it's a lesion that's itchy. So pruritus is a form of pain. So if you're itching, that's actually kind of a form of pain. You ever feel like when you have a scab and it's like starting to get really itchy? That's pain. You're perceiving pain. That's what itchiness is.
Or like stinging, it causes pain. Or
Itchiness, yeah. Anytime you get an itchy type of sensation, chickenpox, right? You get really, really itchy when you have chickenpox. That's pain perception. And that's going to be involving the C fibers. Remember, C fibers are unmyelinated, and they're going to be associated with your second pain, right? So it's the more kind of like dull, prolonged, persistent type of pain. Histamine and substance P are both going to mediate that type of pain, right? Histamine, that's going to be associated with your typical inflammatory reaction and response, especially with mast cell degranulation. You also get that from basophils as well. And then substance P, right? That's the one that's blocked by opioids. Like when you stimulate the mu receptor, it's going to block substance P. So here's that system. Itch, histamine receptors are going to be associated with this. You also have gastrin-releasing peptide. There's something that I just realized is that this is the old version. I actually included a couple new links for this, so give me 1 second as I upload the new version for this. And if you guys want that, it has like a couple new links from a. I'll point that out when we get to it. I updated these today, so give me 1 second. I apologize. So while that's uploading, actually, there we go, it's done. What slide are we on? We're on slide 23. Thanks for bearing with me there. So these are the regions that are associated with itch, right? So it's going to be thalamus, you get your primary and secondary somatosensory cortex, anterior cingulate gyrus, and your prefrontal cortex are going to be associated with the receiving and processing of that type of information. Interoception versus exteroception. Interoception is awareness of your internal environment, right? It could be your emotions, it could be things like social behavior, but it could also be things like thirst, right? Heartbeat, if you have cramps, right? Anything that's happening within the body, whether it's psychological or it's somatic, so both psychosomatic. So that's interoception. That's going to also be mediated by the anterolateral system, specifically at lamina 1. So if you looked at the rex lamina, the region that's like closer towards the tail end of the dorsal column, that's going to be where you have interoception and exteroception being mediated. Exteroception, that's external environment, right? So whatever stimulus you're getting from the external environment, that's exteroception. Again, noxious and innocuous sensation can be transmitted through the anterolateral system. So all these, pain, burning, muscle activation, metabolites, right? Like if you're exercising and you start getting like lactic acid buildup, right? That would all be processed and sensed by this system, anterolateral. So it's not just pain and temperature, it's also a couple of other types of sensations as well. The afferents from internal organs are going to be very similar to the other receptors that we talked about in the other parts of the body. So A delta fibers and C fibers. And again, these are associated with your first pain and your second pain, respectively. First pain, A delta, second pain, C fibers. Dorsal root ganglia are going to be also associated with that as well from the GI tract. So in other words, dorsal root ganglia is going to be really important for basically the majority of your afferent input. There are cases where people can become hypersensitized to pain sensation. So we call this hyperalgesia. Hyperalgesia is where you start perceiving a stimulus to be more painful than it should be, right? So here's a really good graph. This is from a study. I'm not going to try to pronounce their name, but anyways, the study was published in 2009. It shows normal pain, that's this major black line over here, versus hyperalgesia. That's all these little red arrows right here. So in other words, a stimulus that is like less threshold as what would be under normal situation to cause pain, it would be less threshold to actually cause pain in hyperalgesia. Allodonia is even worse than that. Allodonia is where even a stroke of a feather, a gust of wind, can cause excruciating pain. So really, really horrible conditions. Peripheral sensitization can be due to mostly inflammatory process. There's a lot of things that come into play. It could be due to immune cell involvement, different types of peptides, neurotransmitters, lipids, cytokines. Lots of different things can cause peripheral sensitization. But long story short, inflammation is going to be the underlying cause of that. What's the purpose of pain? It's basically to say, hey, there's something wrong, right? Pain is a good thing, unless it's too much, right? If it's like hyperalgesia, allodonia, that's not good. But normal pain is a good thing. Why is it bad? Well, first of all, why do diabetics sometimes have to get foot amputations?
Because
They can't feel the injury. Yeah, absolutely. They can't feel the injury. They have peripheral neuropathy, right? They destroy the blood vessels. They also destroy the nerves that are going to be sensing pain. And then all of a sudden they get a cut on their foot. The cut gets infected. They don't notice it because they can't feel it. And all of a sudden the infection makes its way to the bone. And once they get osteomyelitis, they have to get amputation. There's some cases where you might be able to salvage it with like antibiotics, but usually they have to like cut that affected area off. And so pain is actually a good thing. It helps to like tell you that there's something wrong, right? You are aware of it, right? You're not going to maybe subject it to bacterial infection. You're going to bandage it up. You're going to address the pain, what the root cause is. What was your question?
Could you please give me an example for hyperalgesia?
Hyperalgesia, you can get that from peripheral neuropathy. So there's neuropathies that can cause that. So even like diabetic peripheral neuropathy, people do lose sensation, but sometimes they actually get more of a burning type sensation. You can also get that from multiple sclerosis. Remember we talked about multiple sclerosis, trigeminal neuropathy? That's basically like an allodynia, right? That's basically allodynia affecting the trigeminal nerve.
What about when people don't even get pain syndrome?
When they don't what?
With people that don't even have that type of stimulus.
In general?
Like, yeah, I've heard of it. I've watched the show.
Where they literally feel no pain whatsoever?
Oh, I know what you're talking about. They can like put their hand on a stove and have no idea that it's not fun.
That can happen for a lot of reasons. It could be like neurological. It could be a type of neuropathy. There's also like leprosy can also cause lack of pain sensation. Yeah.
I remember there was a girl that played soccer and they could kick the shit out of her shin.
Women in general have a higher pain threshold than men, right?
Yeah, but this was like no pain.
This is like literally she was just getting her shins bashed in and she was feeling nothing. That's incredible. And that's not a good thing. It's not good because she could break her shin. She could break her tibia and not even know it, right? And then continue to do stuff
Like,
until...
people would bully her in school and she'd be fine, dude.
Wow. That's amazing. All right, so this is some of the extra stuff that I added. So hyperalgesia, it could be due to this calcitonin gene-related peptide or CGRP. If you block this, then you can block certain like pain in certain conditions. So let's watch a little video on this. This has to do with migraines. So kind of cool.
Number 10, immunologics for migraine prophylaxis.
Throbbing pain, nausea, sensitivity to light. These debilitating symptoms of a migraine are incapacitating nearly 38 million Americans, an estimated 12% of the adult population. Sufferers are forced to call off work or cancel plans, taking a toll on quality of life, career, and finances. But now, the arrival of a new class of medications is providing relief through the prevention of migraines. The drugs work by blocking the activity of a molecule called calcitonin gene-related peptide, or CGRP, which spikes during a migraine, causing brain inflammation and pain. Given once a month by injection, clinical trials showed a reduction in headache days per month when compared to placebo. Today, 3 CGRP inhibitors, as well as the first ever intravenous CGRP inhibitor migraine prophylactic, are FDA approved for both chronic and episodic migraines. Currently being prescribed with no signs of slowing adoption in 2021, these new treatments are helping countless migraine patients head off pain and reclaim their personal and professional lives.
So that's from the Cleveland Clinic. So that's a really cool new approach to treating migraines. I mean, there's been lots of different approaches for migraines. Sumatriptan, the triptan drugs, which are serotonergic in nature, they bind to the 5-HT receptors. Obviously, NSAIDs, obviously caffeine pills, opioids have been used in extreme cases of migraine. But that's a really cool approach if you take an injection once a month, and that can stave off the migraines for an entire month. So that's a calcitonin gene-related peptide blocker. NSAIDs, how do NSAIDs work? They are cyclooxygenase inhibitors. So they block cyclooxygenase, or COX. There's COX-1 and there's COX-2. What does cyclooxygenase do? It converts arachidonic acid into either prostaglandins or thromboxane. For this class, we're not going to talk about thromboxane because thromboxane is associated with platelets and coagulation process, right? Which can help to prevent stroke, but we're not going to talk about that today. Prostaglandins, on the other hand, are really important for pain and inflammation. If you have prostaglandin release, you're going to see pain and inflammation in those areas. If you block cyclooxygenase, you reduce the amount of prostaglandins that are produced. And by reducing prostaglandins, you reduce pain and inflammation. That's why if you have a headache or if you have a fever, which can be moderated by prostaglandins, you can take an NSAID, ibuprofen. It can help reduce fever and it can reduce pain and inflammation. So make sure you know just the basic pathway of this. right? So COX, cyclooxygenase, prostaglandin formation, etc. You don't need to know the ones that are like non-selective, like ibuprofen's a non-selective, aspirin causes irreversible inhibition of COX, paracetamol is selective, cyclooxygenase 2 inhibitors. You don't need to know those details. That's just their FYI if you're interested. So here are other things that mediate pain, right? There's lots of different peptides and neurotransmitters that mediate pain. So you got ATP, which can act as a neurotransmitter, prostaglandins, which we just talked about, histamine, which causes inflammation, substance P obviously causes pain. Protons are going to create an acidic environment, which could cause pain. Serotonin can also mediate this process. Also interleukins, which are IL-1. You also get IL-6 release, which are just cytokines that communicate. Tumor necrosis factor, and even nerve growth factor can be involved in these processes too. I'm not going to test you on all of these, right? The main ones that I want you to know would be histamine, substance P, prostaglandins. Those are like high yield, okay? So I'm definitely going to have questions about prostaglandins on the next exam. So here's your allodynia. The reason why this happens is you have too much excessive stimulation of those second order neurons. Remember, first order neurons come from the periphery. Second order neurons is where you have synapses at the spinal cord, which make their way up to the thalamus. And then you have your third order neurons from the thalamus to the somatosensory cortex. So allodynia is excessive stimulation of those second order neurons. There's another thing called a wind-up phenomenon. In your textbook, they just called it wind-up. But if you like try to do research on wind-up, you're not really going to find much. So it's called the wind-up phenomenon of pain. What happens is that you get progressive excitability. It keeps on increasing and increasing, despite the fact that the stimulus itself is not even taking place anymore. So even as you stop the stimulus, when you remove a stimulus, you're going to keep on getting this like increase of pain. So this has to do with basically low frequency activation of those pain receptors, nociceptors. Why does this happen? It has to do with the NMDA receptor. So the magnesium ion gets booted off the NMDA receptor, and now that receptor is more excitable to glutamate release, right? It becomes more sensitive to glutamate. So that's the wind-up phenomenon. Here's another video that I included, but it's kind of like he's talking about migraines, but it wasn't as good as the video that we watched from the Cleveland Clinic. It's another doctor talking about how he treats migraines with this calcitonin gene-related peptide. It's pretty new stuff. This has come out recently, this approach where you block CGRP to treat migraines, which is really cool. Now, here's phantom limb pain, which I'm sure all of you guys have heard about before. If a person gets an amputation for whatever reason, sometimes they'll still feel the limb. They'll still feel like it's there. Like they'll still feel their toes. They can feel their toes like curling up. They'll feel their muscles stiffen up like crazy. That's because the nerves that are associated with that reception, the nerves are still there, right? But the neurons are not getting like proper input anymore from the actual appendage that was lost. And so you get kind of like, the brain gets really confused. So it becomes like a psychosomatic type of pain, and it's excruciating. Some people suffer from extreme amounts of pain from phantom limb pain. Burning sensation, tingling sensation, but also just cramps. Like they feel like the muscles that are no longer there, they feel like those muscles are just cramping up and becoming spastic, which is excruciating for these patients. Let's watch a little video on phantom limb pain. 2-minute neuroscience.
Phantom limb is a condition in which someone who has lost a part of their body continues to experience phantom sensations coming from that body part. Despite the name, phantom limb doesn't only occur in limbs, and has also been recorded after the loss of other body parts like breasts, genitals, and even teeth. Phantom sensations are thought to be experienced by almost all amputees, and most suffer from some degree of phantom pain. Scientists have proposed a number of hypotheses to explain phantom limb, but the phenomenon is still poorly understood. The prevailing explanation is an idea known as cortical reorganization. According to this hypothesis, when a limb is lost, the neurons in the somatosensory cortex that used to respond to signals from that limb begin to respond to signals from other nearby neurons. This can cause sensations felt in other parts of the body to lead to the stimulation of neurons in the somatosensory cortex devoted to the now missing limb, which causes the brain to perceive sensations in the missing limb. Another hypothesis suggests that your brain maintains an internal representation of your body, which aids in body positioning and movement, among other things. But when a limb is lost, the body representation can remain intact. This persistent neural representation might lead to the sense that the limb is still there, and could even generate pain when the intention to move the limb is discordant with the lack of sensory feedback from the missing body part. The peripheral nervous system might also be involved. When a limb is lost, damaged neurons often attempt to repair themselves by growing new extensions. But without a limb to grow into, the new extensions have nowhere to go, and they form a massive neural tissue called a neuroma. The neuroma can generate erratic signals, which may underlie the sensations and pain associated with phantom limb.
Cool. So I'm going to show you how this can also be treated in a clinical setting by using either mirror therapy or the mirror box therapy. Ramachandran is the doctor that created the mirror box therapy. It's like absolutely freaking brilliant that he came up with this because it alleviates the patient's phantom limb pain sometimes instantaneously. So basically they have a mirror and you're just seeing a reflection of the limb that you still have, but then now you have the mirror and then you see the opposite limb as if you still have that limb there. And then you move your limbs together and then it basically tricks your brain into thinking that you're able to move those limbs again. So if you have like a pain where you feel like you're getting cramps or like the muscles are spasming, you can relax that out just by doing mirror box therapy. It's an incredible way to treat that. So here's a couple of videos on that whole process.
It's a pain people with amputations may feel in an invisible limb. But Dr. David Burbrayer, a physiatrist at Sunnybrook, explains phantom pain is very much real.
The phantom pain is coming from the brain. It's a perceived impression, what we call an engram. The brain has a picture of your residual limb that's absent.
Bruce Tompkins lost his leg when an infection settled into his bones and he developed an advanced stage of localized osteoporosis.
I was actually walking on 6 broken bones when I was finally diagnosed. And I only had really 2 choices: to live with the amount of pain that I was living in and not walk normal, or lose the limb and start a new life with a prosthetic, and I chose the latter, of course. There was a month at least where I went through a mental crisis saying, how can a leg that I don't even have cause this kind of pain, you know? The phantom pain that I get daily, which I still get, is just kind of a tingling and a numbing. It just allows you to realize that feels like your limb is still there. But the severe phantom pain, I can only describe it as your foot being in a bucket of water with piranhas in it, or hot coals. It gets so debilitating that I've actually huddled into a corner and just cried myself to sleep because it just won't go away.
So how can you treat pain in a limb that doesn't exist? Experts say with a mirror and an open mind.
Mirror therapy is using a mirror between the limbs in order to allow the brain to think that the intact limb is the absent limb, and then allow a professional to treat the intact limb as if it were the absent limb. And go. If, for example, the toes are curled up and on the absent limb, as the patient perceives it, if they could move the toes on the intact limb and move it up and down, the brain will tell the individual that the toes on the amputated limb is now moving, and that will allow less pain and less discomfort in the individual. And that's an example, and it works. It's effective in terms of treating pain.
And I had a full-blown attack on the Saturday night there. One of the ones that would have made me medicate myself and just curl up and just pray that it would go away. And about 20 minutes using the mirrors, it was completely gone.
But Dr. Burbrayer warns mirror therapy may not work for everyone. Patients need to be emotionally and mentally ready, willing to try, and persistent in using the mirrors.
It's going to be a lifelong process, but I think for now it's the results are fantastic. I'm not afraid of getting up in the morning and how much pain I'm going to deal with all day. I have a way to deal with it now that is working. And the more I work it, the more it'll work for me. And
Yeah, that's awesome. They've also done some research using serotonergic compounds like psilocybin. We talked about when we were discussing like neurotransmitters before that these compounds are actually being used more and more in like clinical therapy. It actually helps to increase the efficacy of phantom limb mirror therapy, mirror treatments. So pretty cool stuff. You had a question?
I was literally gonna ask, like, if you essentially did like a mushroom thing with somebody and then like psychologically got them ready for this.
There are studies out there. There are studies out there that report extreme success coupling those two together, right? Because you're basically helping the mind basically open up to a new experience.
Yeah.
And so it really, really helps a lot. So here's Ramachandran, who's that doctor. Again, super brilliant idea. This is the guy that came up with this. Super cool.
James Peacock has suffered excruciating pain since he lost his hand 6 years ago.
A few days after I woke up, it might have been a week to 8 or 9 days, something like that, before the pain really started getting bad, to where it was like your hand is just crunched up real tight and stuff, or balled up, and you can't move it. To unclench it, it's just, you can't. You try in your mind.
This raises a perplexing clinical problem. How do you treat pain in a body part that's missing? James tried everything, from painkillers to hypnotism, but nothing worked.
Until I found out about the mirror box.
It was then that he came to see Ramachandran.
One answer might be that the brain is sending signals to the arm and trying to clench it. But in you and me, there's messages going back from the muscles of the hand telling you you're clenching too much or too fast. And this damps the command signals, so you can slow down. But the patient has no feedback because he doesn't have an arm. So the brain says, send even more signals, okay? And this goes on, you get into a sort of positive feedback loop. So I said, well, if you give him some other source of feedback, such as visual feedback, maybe that'll trick the brain into thinking that the hand is clenching or unclenching, and maybe you can interrupt this loop. So I said, well, why don't we put a mirror there and have James look inside the mirror? Just as though you have visually resurrected the phantom limb. And of course, the patient knows it's an illusion, but it's very, very compelling.
Right now, as you look in there and you move your hand, your phantom does the same thing as your left hand is doing. First time I got in here and I've done this, and it was just like, it relieved the phantom pain, unclenched it. It was just, so intriguing, sometimes it's hard to explain how you felt,
Ramachandran believes the mirror box needs to be evaluated with many patients before he can be sure that it really works. But its undeniable success in uncramping James's phantom hand suggests that even pain can be a construct of the mind.
Isn't that amazing? It's so amazing. It's really incredible. I mean, absolutely brilliant for Dr. Ramachandran to even begin to think that was a possibility, right? To put a mirror there to help trick the brain. Awesome stuff. Yeah.
Okay, so I have two questions. So in exercise science, we would talk about the phenomenon of you break your right arm, you continue training your left arm, and it builds the strength up in your right arm. And I think it's called cross communication, but it's not well understood as far as I know. And every time I've looked it up, I can never get answers of why that happens.
Yeah, it probably has a lot to do with.
I was gonna say that sounds like it's related.
Totally.
And then my other question is I've never known if this is actually a fact, but then I've seen a lot of stuff that seems like it is, where they say the body holds psychological stress in certain parts. So is this a thing too, where you can have a traumatic experience and then psychological, I don't even know, it makes me very confused when I try and figure that out. But,
I mean, there's a book called The Body Keeps the Score.
Yep.
I haven't read it yet, to be honest with you. It's sitting on my bookshelf in my office actually right now. I bought it last year. But I don't really know enough about that to speak on that. Okay. But yeah, I mean, weird stuff happens, right? When there's psychosomatic conditions, right, that have to do with your psychological mindset, which affects your physiological functions. So, yeah, I mean, I think that's interesting. The first one, definitely, there's a definite connection there.
I have like a friend. He's an actor, so he's like an acting major, and they do like body stuff, not like exercise classes necessarily.
Oh, yeah.
But, like, you know, like they like.
I know exactly what you're talking
Yeah.
about. Yeah, I did a little bit of like theater performance and stuff, and so like part of like the the training and whatnot, you do like physical type of activities.
And they'll
right?
have like times where someone starts like uncontrollably crying,
Oh.
or, like screaming, and he's like witnessed this many times.
Interesting.
And he was like asking me, "Do I know what's going on?" And I'm like,
Interesting.
"Bro, honestly, I have no idea, but that sounds like it's that kind of."
That's very interesting.
Yeah, crazy.
Yeah, that's interesting. I mean, there's also been like studies about like body posture and how that affects your mind.
Yeah.
But some of these studies have not been well replicated, but I don't think that they're false. Like there was a study that's like, oh yeah, if you go into a power stance, so you put your
I saw that.
yeah, and it increases serotonin. They actually couldn't prove that scientifically.
Okay.
Really?
Yes, she used to make us all stand up and do it.
In the power stance?
Yes.
For how long? Like a minute? 60 seconds?
She was handing out exams.
That's so funny. I heard of people doing this before a job interview. They'll go to the bathroom and they'll do a power stance for a minute, and then they'll go to the interview, and apparently it's supposed to like help you perform better. I mean, the science on it is unclear, but I mean, there's anecdotal evidence that supports that. Who knows? If you walk around stooped over, staring at the ground, you're probably going to feel more depressed, right? Just because you have a more depressive type of like posture. And so, yeah, I wouldn't doubt that there's a connection there. Is it going to be something that can easily be proven by experiments? I don't think so. Maybe, but who knows? So, anyways, again, here's your mirror box therapy. These are the different types of phantom limb. All the purple areas over here, these are like phantom limb. It can go literally all the way up to where the amputation took place, to the the leftover stump area. But horrible stuff. Placebo effect. This is another really interesting one. Do you recognize this? Yeah, I took it from Paul Stamets. I tried to find it online too. I'm like, where did he get this? And the only place I found it was on his Facebook page. Placebo effect. So I'm guessing we're in the placebo group. All these folks over here. Anyways, so the placebo effect. This is like a real thing. A lot of drugs have been found to literally elicit their effect through placebo. Right. And what's a placebo? It's effectively a sugar pill, right? They have to do like control studies, even like with control studies where the control is the placebo, they'll find a therapeutic benefit. The person, the patient, or the subject in the experiment will literally report therapeutic benefit when just taking a placebo. So the placebo effect is real. How is it mediated? It's thought to be mediated through the opioid system. So if you take a drug like naloxone, which blocks the opioid mu receptor, that actually blocks the placebo effect. The mind is powerful, man. It's a really powerful thing. Where is this mediated? It's going to be areas like the anterior cingulate cortex, as well as the insular cortex and the amygdala. Those are all areas that are, pretty heavily associated with the limbic system, emotional system. Right? So really, really interesting stuff.
So that's for all like placebos that happen?
It depends on what it is, but I would imagine a placebo effect that has to do with maybe like feelings of well-being, like a positive feeling, either emotional or like pain mediation, that would be moderated mostly by placebo. Like a cancer drug, I don't think so.
Okay.
I think it depends on what type of therapeutic you're talking about.
Okay.
Yeah, it probably has to do with more of like something that actually, yeah.
I'm like, we are talking about pain, so I would.
Yeah.
That makes sense.
Yeah.
In context. Okay.
Physiological moderation of pain. There's also electrical signals that can be sent that are going to moderate pain, as well as pharmacological stimulation. So there's different types of approaches in moderating pain. These are the regions that are going to be involved in pain as well. So you got the parabrachial nucleus that's going to be associated with all sorts of different types of feelings like temperature, pain, itch, taste. You have the reticular formation. Again, it basically arouses you to something that might be something you should pay attention to. The dorsal raphe, that's where you get serotonin production. That's going to affect mood, anxiety, etc. Locus coeruleus, which is going to involve also alertness because of norepinephrine production and release. And then You also have interneurons that are going to be involving things like enkephalins, which is what some of your natural endogenous opioids. Where do those types of compounds come from, like endogenous opioids? The periaqueductal gray. In the periaqueductal gray, you get 3 of your major your endogenous opioid compounds. So enkephalins, endorphins. Right, we're going to talk about those again in a second. Also, serotonin, dopamine, norepinephrine. Those are all going to be involved in pain moderation. And when it comes to the dorsal horn within the spinal column, so this is your body's way of moderating pain. You know how like you go on a jog or something like that and all of a sudden you get this rush of like endorphins, right? That's kind of like your body's way of moderating the pain from the exercise that you just went through. So you have bottom up and you have top down moderation. This would be like top down type of moderation of the pain. And this is going to involve both excitatory and inhibitory neurons. So if you get injured for whatever reason, your body does release endorphins to try to minimize the pain, to dampen those sensations. So that's going to be kind of like that top-down approach. This is the modulatory system of pain. So this is the top-down descending system. So it's going to involve the somatosensory cortex, the cingulate cortex, insula, amygdala, hypothalamus, Raphe nucleus, periaqueductal gray, right? These are all involved in the top-down moderation of pain. Now, there's a theory called the gate-controlled theory of pain. You ever, hurt yourself and then you kind of like, that really hurt. You try to rub the area, right? So basically what you're doing, you're actually creating other stimuli. So now your brain gets kind of focused on the other stimuli to kind of distract you from the pain. There was a study that I wasn't actually involved in. I was going to be one of the co-authors on it, but it was a student here who works with a orthopedic surgeon. And this orthopedic surgeon, he does a lot of cortisol injections for trigger finger. Trigger finger is where your finger gets locked up, and it has to do with some of the tendons and the tissues within the palm of your hand. And so when you inject cortisol into your hand, that's a really sensitive area, right? Your hand has a lot of sensory pain receptors. And so cortisol injections can be very painful for some people. The thing that they did to basically distract the brain was basically just doing you kind of massage the area nearby where the injection site's going to be. So it basically distracts the brain from the actual pain sensation from the injection. So that basically involves the gate control theory of pain. So activation of mechanical receptors modulates the transmission of nociceptive information to the higher centers. So basically you're distracting the brain effectively. So let's watch a little video on this.
The gate control theory of pain states that the transmission of pain signals can be modulated at the spinal cord level by non-painful inputs as well as descending signals from the brain. Non-painful inputs typically close the gate to painful inputs, reducing pain. Pain sensation is mediated by pain receptors or nociceptors, which are essentially nerve endings of first-order neurons in the pain pathway. The axons of these neurons form small diameter nerve fibers of 2 types. Fast fibers A delta, responsible for the initial sharp pain perceived at the time of injury, and slow C fibers, responsible for a dull, longer-lasting pain. First-order neurons travel by way of spinal nerves to the spinal cord, where they synapse with second-order neurons, which, together with third-order neurons, carry pain signals to the brain. However, according to the gate theory of pain, perception of pain is not simply due to stimulation of nociceptors. There is a so-called nerve gate located in the dorsal horn of the spinal cord that controls the passage of pain signals to the brain. This nerve gate consists essentially of interneurons that inhibit second-order neurons, thereby stopping or reducing signal transmission. When nociceptors are activated, they stimulate second-order neurons and, at the same time, inhibit the inhibitory interneurons, thus opening the gate, allowing transmission of pain signals. Now, if the area is also stimulated by other non-noxious stimuli such as touch, pressure, or changes of temperature, a different type of nerve fiber, large diameter A beta, is activated. and this reactivates the inhibitory neurons, stopping the transmission of pain signals. This mechanism underlies the pain-relieving effect of skin rubbing or heat or cold packs. It is also the basis of pain treatment procedures such as transcutaneous nerve stimulation, which delivers a small electrical current to activate non-nociceptive receptors in the skin. The brain can also send signals to the spinal cord to modulate the pain gate. Examples of such signals are endorphins, morphine-like substances released by the brain in response to pain. In addition to lowering pain perception by the brain, endorphins reduce transmission of pain signals between the first and second-order neurons by two mechanisms: preventing the release of a key neurotransmitter, substance P, and inhibiting action potentials in postsynaptic neurons. Production of endorphins may be induced by a number of factors, including pleasurable activities, excitement, meditation, laughter, and vigorous exercise. Endorphins' action underlies the pain-relieving effect of physical exercise, positive state of mind, and explains, for example, why athletes may not feel pain from an injury until the exciting game is over.
So cool. Right? That's why if you go to a punk rock show and you go into the mosh pit and you're just like beating each other up, everything is cool and stuff, right? Because it's fun. But then afterwards you'll feel the pain. Right? Have you ever like had I remember sometimes like my feet would be kind of like hurting, but then you like start walking or like maybe like doing like a jog or something like that, and then the pain kind of goes away at the time. You guys ever experienced that before? Right? That happens all the time. That's basically what's going on over here. It's basically you're distracting your brain from the actual pain itself by blocking or actually stimulating those interneurons, or just the endorphins in and of themselves are going to be reducing the total amount of pain. So here's Melzac's and Wall's gate control theory of pain. Again, you get activation of those low threshold mechanoreceptors. They mitigate the ascending nociceptive signal. And again, this could be like if you accidentally, injured yourself, you hurt yourself, kind of like what's going on in this video. Anyways, it goes on like that for like 30 seconds. So you rub your knee when you get an injury, right? And then it helps to make the pain go away. Unless you're, what's his name? Peter Griffith? Yeah, it didn't quite go away, unfortunately, for him. So here's the periaqueductal gray. Again, these are your endogenous opioids. You get three major types: enkephalins, endorphins, and dynorphins. Those are all released by the periaqueductal gray. And those are basically what allow for the reduction of those pain stimulation, especially from your second order neurons. So they are at that first synapse between the first order and second order neurons. And endocannabinoids are also going to be involved in this process too. So endocannabinoids are also going to be released in the periaqueductal gray. So it's not just your endogenous opioids, it's also your endogenous cannabinoids. And it basically decreases pain transmission once you bind to the CB1 receptor, right? So it's going to help moderate pain in that regard. Decreased release of GABA and glutamate. Remember how endocannabinoids work? They have kind of like that retroaggressive, retroactive communication from the postsynaptic cell to the presynaptic cell, right? Then they bind onto the CB1 receptor. Then it blocks GABA from being released. That's kind of the overall process going on over here. And then if you had a CB1 antagonist, that would block the analgesic effect caused by electrical stimulation of the PAG. So if you had an antagonist against these receptors, it would basically cause pain again. So let's do like one or two questions from quizzes before we move on to vision. And it's already 2:11, man. These lectures are so long. They're not long enough. There's so much material to cover, but anyways, go ahead and sign in. We'll do like maybe one question on here, and you can do the rest of them on your own time. Okay, so free nerve endings, nociceptor, unmyelinated C fibers. Okay, C fibers are not myelinated. So your A delta fibers, which transmit your first pain, sharp pain, those are lightly myelinated. So they do have myelin on them. And that's why they're faster. Right? The C fibers are much slower because they're unmyelinated. So in other words, free nerve ending receptors are going to be stimulated. Then you get unmyelinated C fibers, which are going to transmit that signal to the spinal cord. So these are your first order neurons, and they synapse with the second order neurons that go eventually all the way up to the brain. Anterolateral system. Are we good on that? Yeah? What confused you guys on this one? You accidentally clicked it? Did you guys all accidentally clicked on it, right?
I definitely did not.
No, I knew it was a mile. I knew it was a mile.
Okay. So it had to do with myelination. All right, one more question, and then we'll move on to vision. All right. So, what is this condition called? Yeah, this is allodonia. Good. So, inadvertent stimulation of second order neurons. Right, the second order pain neurons, right? That's what's getting overly stimulated in allodynia. So it doesn't have to do with demyelination of the secondary neurons. If you demyelinated those, you would have reduced sensation, basically.